thank you, Dr. Vivek. Wonderful talk. One comment is actually coming from Dr. Milton Packer, and he was asked, how will you envisage heart failure arena in next 10 to 15 years? And one of his major comments was that engineers will take over, and LVADs and LVSS devices will see miniaturization, and at least as a partial remedy for the lack of hearts in US. Your comment about that?
Yes, I fully concur with that, because if you see because you need to see to believe it, and we had 20 odd patients where there was no hope. We had one of the oldest patient, 82-year-old lady who was flown in from Africa, and she was otherwise very fit, and everywhere it was said that why do we want to live? Why do we want to spend money? It's an old lady. She has already lived her life, but she was very adamant, and she was from a very rich family. She got the HeartMate 3 and she started doing normal activities and was very happy. So I think you are very right, and I think the Milton Packer's futuristic statement that probably if we have got any answer for end-stage heart disease, this is going to have. If you see, previous talk was about CRT and all, and half of our patients were candidates who were on CRT for quite few years, and then they had to be offered LVAD after 7-8 years, maybe 9-10 years also. So I think this is going to be the future, and but we are not yet perfect, so engineers have to work a little more on that.
Dr. Ashish, your comments?
Sure, Dr. Oman. Actually, I wanted to have your comments on, for the benefit of the attendees, on how the ARNIs and SGLT tools have changed the indication for CRTs and ICDs.
Okay, so few statements. First statement is that these medications have to be used early in the journey of heart failure, because like Dr. Ullas also said, when it reaches 3 or 4, this may not work. And with ARNIs, the German paper, they showed that the people who already had implanted devices, they showed that the VT burden, VPC burden, everything came down. And again, Milton Packer, he has written a beautiful article about a perfect storm. And actually, the sudden cardiac death in very sick patients may not be an electrical event, it may be a mechanical event. And by controlling the other factors like preload, afterload, contractility, the ARNIs can reduce sudden cardiac death. And there's a beautiful paper by Chen et al. In NEJM a couple of years back. The incidence of sudden cardiac death is coming down, and it's quite a bit with the physiologists like Dr. Ullas and his team, and also because of good medical therapy. Again, SGLT2 inhibitors, we have shown that there is data, and also again subgroup analysis as well as meta-analysis, that the VT burden may come down. So my take-home messages are: 1, start these guideline-directed medical therapies early and don't hesitate, even if the patient, quote unquote, is very less symptomatic. There is no mild heart failure. They reduce the incidence of sudden death. And there is another study, PROVE-HF, which has shown that if they're on optimal guideline-directed medical therapy, especially with ARNIs, and about 65% of the people in 6 months, their EF improved to more than 35, and 35 was the cutoff, as beautifully shown by Dr. Ullas. So guideline-directed medical therapy should not be forgotten. And lastly, but not the least, in these trials, irrespective of the patients had both DAPA-HF and Emperor, whether the patient had undergone CABG or not, there was benefit with guideline-directed medical therapy. So don't forget guideline-directed medical therapy. Never ever forget the devices. And all these start early in the course of the disease. That would be my comments.
Just a question to Dr. Vivek Kumar. How expensive is LVAD?
Yeah, so I think that's a big thing. The LVADs still, they are costing around 60 lakh rupees. So if you look at the HeartMate 3, it is 60 lakhs. HeartMate 2 now, this is available in 25 lakh rupees. So I think it has become cheaper. But the HeartMate, the HVAD which Medtronic was giving, they have withdrawn because of the complications. And also we have only HeartMate 2 and 3 available. There is an Indian company where we were part of the trial where they have yet to start. So that they are planning to keep a price of around 15 lakh rupees.
So, Dr. Mahapatra, now that you raised the issue about the cost, can I chip in for a few seconds? Yes.
Sure, please.
You see, I think that was a great talk from Dr. Gokhale. He had mentioned about several challenges where, the heart transplantation and LVAD are not picking up in the way we are expecting it to pick it up. I think cardiologists could be blamed, electrophysiologists could be more blamed. I think at the indication for a CRT or a CRT-D, there could be a chance instead of that CRT or a CRT-D, we need to be pushing them towards the LVADs or the transplant. I think these guidelines need to be, clubbed together. Today, we have guidelines for device therapy, just blinded to the LVADs and the transplants. I think the intervention therapies needed to be under one specific guideline. I think there are situations where we know very, very well the CRT may not work, but as a desperate attempt, just because for the cost, we are making the patient poorer. The same money, if we had saved for a CRT-D in my center, which is probably costlier than many of the other centers, which is about 8 to 10 lakhs. Why don't we ask him to preserve that money to go in for the LVAD by some other means? I think there is a subselect of patients who are really candidates for the LVAD or the transplant and not for the CRT or a CRT-D. If these things are put together, I think we will do a lot justice to our patients with heart failure. Vivek, you sound to be not very optimistic about my idea.
No, so I think I fully concur with you. And I have seen we had given the options to our patients and they said that, so the one of the, I can quote the patient's decision that we will rather, have this money and borrow some more and then go for much more, effective therapy than the going for CRT. And the thing which you have hit the nail right in the center that if you give CRT, the patient becomes poorer in certain indications where, so the data is showing so many times that, class 4 patients where, it has already exhausted. There, neither ARNI has shown benefit nor the CRT would show benefit. So this is something where, it's like a ritual that the patient has done everything before. So the last ditch effort you throw in a CRT. So I think we need to be very careful and there should be very good collaboration. And as you rightly said, the guideline has not to be blinded towards these advanced therapies. So if the community at large is aware, still a lot of patients come to us and say that, doctor, is these therapies, available in India? Is it being done in India? So a lot of them, even the doctor community, very good members of APIs and all, they don't believe that it is being done in India. So I think we need to educate and make it more popular. And I think I fully concur with Dr. Gokhale's opinion also that these therapy has to be put in place and people has to be made aware so that more and more patients get benefit out of it.
I would thank all the chairpersons, Dr. Abraham, Dr. Ashish Nabar, Dr. T. Sundar, who has already left for some transplant work, and all the speakers, Dr. Bala, Dr. Ullas Pandurangi, Dr. Gokhale, the best, all the speakers, they have done a very good job. And thank you very much.